behalf of CME Outfitters, I would like to welcome you to the CME OCast titled Overcoming Implicit Bias and Stigma, Managing Underserved Populations with Obesity to Improve Adherence to Treatment Plans. This activity is brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. This activity is supported by an educational grant from Novo Nordisk. Again, I'm Dr. Robert Kushner, Professor of Medicine and Medical Education at Northwestern University Feinberg School of Medicine. And I'm very pleased to be joined today by Dr. Fatima Cody Stanford, who has several important roles at Massachusetts General Hospital and Harvard Medical School, including obesity medicine physician scientist, Director of Equity, and Director of Diversity and Inclusion. Fatima, thank you for joining on this podcast.
Thank you so much for having me.
Let's begin by reviewing our two learning objectives. After participating in this activity, learners should be better able to recognize the role of unconscious bias and stigma in the management of underserved populations with obesity, and partner with patients to address barriers to adherence and to improve obesity outcomes. Again, Fatima, so glad to be doing this podcast with you.
This is going to be great. I'm looking forward to it.
So, Fatima, I want to start with educational professional obesity initiatives. You know, we can't treat obesity unless we have some education and training in obesity. And both you and I have been involved in education, not only at our own universities, but across the nation as well. So what are your thoughts about where we're at regarding training our medical students and other healthcare providers?
So, Dr. Kushner, one thing that I am truly disappointed by is our lack of education surrounding the disease of obesity to medical students, residents, fellows, and attending and practicing physicians throughout the country. What we do know is that this is undertaught and underdelivered within the medical system. Your studies, my studies continue to support this, not only here in the US, but around the world. And what's really disturbing about this is that we know obesity to be the most prevalent chronic disease of our lifetimes. Yet, many people know how to treat very esoteric, what we call the zebras of medicine, as opposed to what is clearly a horse. And the chronic disease of obesity has a high prevalence and affects a large majority of the population. Yet our doctors aren't trained to treat this disease.
Yeah, it has been a tough nut to crack from undergraduate to graduate education, from the science and the practice of obesity, and also particularly about bias, which we're going to spend most of the podcast talking about. And I wonder, at your university, Fatima, do you have some particular education going on regarding bias and obesity?
So I can say that individually, when I work with the students that come through and rotate with me here at Mass General Hospital, we do spend some time working on bias. But what I'm disturbed by is that it's really the people that already are invested in this work that are rotating with me, right? The people that select to rotate through obesity medicine. What about everyone else? And I can tell you that there is no large-scale systematic approach to addressing not only obesity as a disease, but the accompanying bias and stigma that patients with obesity often face.
Yeah, so that's great. That's a great segue to actually go into bias. There's a lot about education and obesity, but let's focus particularly on bias. And you want to talk, I know you want to talk about bias in Western society and what that means for different cultural groups and age groups. Can you talk a little bit more about that?
Absolutely, Bob. What we do know is that the two most common forms of bias here in the United States are race bias, followed very closely by weight bias. And so, for example, if you think about the lay press and what we've seen in the lay press, if you did a Google search just back as recently as 2016 for young Black boys, it only returned mugshots, unfortunately, where if you did the exact same search for young white teens, you were met with smiling faces, often holding things like a basketball, things of that sort. And it was after this was published in the Washington Post that Google actually changed its algorithm. So even within our technology, we see this bias reflected. Now, similarly, much like we see these biases with regards to race and ethnicity, we often have significant biases towards persons that have excess weight. We label them as lazy or insecure, undisciplined, having these notions that because of their obesity, they're characterized by these often very negative adjectives. And Glamour actually reported on this back in 2012, when we have not seen a major shift in that thought process. Now, when we see the overlay, Dr. Kushner, between the two, those persons that have obesity who happen to be of racial and ethnic minority status, you can imagine that this is a recipe for significant augmentation of the bias and stigma that they might experience because of the duality of the bias that they will have to navigate because of what we experience here in the U.S.
Fatima, you bring up very important information. I'm glad you're bringing this to light. But I want you to talk a little bit. My understanding is that there's difference in perception of health and body shape among different ethnic and racial groups, where one group may think body shape, being overweight, is unglamorous and shameful, and others it may actually be more attractive. So is there a difference when you bring obesity and racial groups together? Do we need to tease that out a little bit more?
I do think we do. And I think that the literature hasn't done a good enough job with kind of looking at the differences that we experience. As a Black woman, physician, born and raised in the South, I can tell you that body types that typically have more subcutaneous adipose tissue in the hip, buttock, and thigh region, right? More fat kind of in that region is, applauded. There are even wonderful songs that are out that really kind of celebrate this. Whereas if you look more in the non-Hispanic white community, that's less celebrated. Although I think that there's a bit of merging as, the media influences this conversation. Certain celebrities, for example, who have, I guess, really thought to embrace curves. What happens is, unfortunately, this idea of just shape and body type doesn't get, I guess it gets divorced, I want to say, from this idea that someone could have this disease of obesity. And people presume that obesity is just something that's either aesthetically displeasing to certain groups and maybe more pleasing to other groups. And I think that we have to make sure that those two things, that we don't divorce those from each other, that recognizing that the phenotypic or the expression of obesity, how one looks, often is tied to one's health. And I don't think that message gets across, to individuals, regardless of race or ethnicity.
Yeah, I think a good take-home message, and this is a very interesting topic and complex, I think. But I think from a clinician point of view, we want to get away from stereotyping and assuming body shape is felt one way or another, and really talk to the patient and inquire what they're actually feeling and how they would like to be looked at, I think is the bottom line regarding all of that.
Absolutely.
Yeah. So I want to move on a little bit, again, this theme of bias and so forth, and really talk more about toddler bias and maternal anti-fat prejudice. And what do we know about that entire area?
So there are several studies that show that particularly parents and their what we call anti-fat attitudes strongly influence what their children believe. So there was this one large study that came out where they looked at moms and their children, and they would show the children, which were infants at the time, pictures of body types that were, more likely to have obesity versus those that were leaner in nature. And at around 11 months of age, the infants really preferred larger body types. But as early as 32 months of age, they started to show significant preference only for leaner individuals. And this was strongly influenced by what mom's thoughts were. And often, Dr. Kushner, what I have parents tell me is like, well, I don't say anything negative about persons that have obesity, but I tell parents it's also what they're not saying. So if you're watching television, let's say with your child, and you only comment positively about those that appear very lean and never say anything positive about those that have a much larger body type, then that is indirect communication that I do not value or think that is as attractive. And that actually is learned behavior on the part of the child. And so this happens and shows up extremely early in life, and it's really based upon the parents.
Mm-hmm. So I guess, are you referring to, is this like implicit bias that you're talking about, or is that something different?
I mean, I wouldn't necessarily say it was per se implicit bias. Sometimes there is explicit bias. I would give an example to those parents that point out to me that they don't demonstrate any bias. Those are the ones that have that implicit bias that they're not aware that they have.
Mm-hmm.
There are some, however, that explicitly state that they are repulsed by a certain person because of their body type. And so I would say that there's probably a combination in these studies. They didn't really tease out either the implicit versus the explicit bias.
Mm-hmm. Okay. Let me move on a little bit more to adolescence now and outcomes as related to obesity. What kind of studies are we learning about there?
So what I like about some of the studies that are done here is that these are really long-term studies and long-term perspective studies where we're looking ahead 15 years into the, from the time of the start of the study to see whether or not like weight-related teasing in adolescence actually lends to any poor health outcomes once they're in adulthood. And in this large study that looked at almost 2,000 individuals from 1999 to 2015, they showed that when someone was exposed to weight-biased teasing and bullying, either from their peers or from their family, it really portended worse body mass index, worse health status later in life. And that's problematic because people assume that, oh, they just need to get over it. They just need to get thick skin. But we actually see this leading to poor health outcomes. Is this just about, being able to tolerate the negative language that they're getting from individuals? No, it actually leads to poor health outcomes. And so why engage in behavior where, you have this unhealthy eating, binge eating, disordered kind of control of weight, leading into this vicious cycle that just really portends negative outcomes later in life. It starts early. And if we can really do things to really address this in adolescence, we know that these adults will have a much better health-related quality of life.
Mm-hmm. So is this in part the term that a lot of us have heard about is internalized bias, where you internalize these perceptions of society and what you hear and lead to poor outcomes. Is this kind of what you're talking about? Does that apply?
Absolutely. So what you experience, you internalize, that then leads to your self-view and how you decide to navigate the world. Absolutely. That's exactly what we're talking about, that internalized bias leading to, unfortunately, poor health outcomes.
Mm-hmm. And what do we know about the literature, bringing in, again, individuals of color, minority groups, and so on? Does it seem to affect them as well, or do we know enough about that?
Yeah, I think that, if you look at the actual studies that have been put out, Bob, we don't really see the delineation between which groups experience what. In this particular study that I was just talking about, they did have a diverse cohort of individuals, but did not control for race in their analysis. And so, like I said, I think that much of the work that, precedes or, from the work that we have seen done really needs to focus in and hone in on some of the differences that we might see across racial ethnic lines.
Mm-hmm. So, Fatima, for those of us who are either in family medicine or in internal medicine, which is my own case, where I'm not seeing my patients as children, but they have this legacy, this bias they grew up with. And I wonder, do you have any recommendations of what we should be talking to our patients about that may try to uncover some of this bias and stigma and discrimination may have occurred earlier that they're bringing to the table as adults? Do you have a recommendation of how we can explore that or should explore that further with our patients?
Absolutely. I'm glad you brought that up because I think that unfortunately a lot of patients, adult patients, bring to the table, unfortunately, the baggage they've accumulated along their life, often that have had a lifetime struggle with their weight. And what that means is that when they come to that appointment with you, they put up a bit of a wall. That wall may take some challenges to navigate in terms of how do you discuss their weight with them. Maybe they assume that anything you bring up with regards to weight and obesity is going to be negative because that's been their historic legacy of how they've interacted with pediatricians or their family or friends. And so I would start off by asking them, first of all, how do you feel about, discussing your weight? Would you like to discuss this? And what terms would you like for me to use to make sure that this conversation feels comfortable for you? These things can help set up the narrative that you are there, you care, and you want to support them in a way that they would like to be supported.
Yeah, that's certainly patient-centered care that you're bringing up. And I think we're learning a lot about the history of sexual abuse or molestation. A lot of us are very sensitive about that with our patients. But this brings up a whole nother area that anyone who comes in with childhood obesity or adolescent onset obesity can have this background and these thoughts and feelings that we really do need to explore to really connect with our patients. So you brought up some really very good points.
Yes.
I'm going to move on to another area, which, of course, we're all coming out of this pandemic as this podcast is being taped, of obesity and COVID-19. And Fatima, as you know, this is at least I could think of, the first serious acute problem that is really affecting individuals with obesity. It's always been a chronic relapsing disease and problems down the road with cardiovascular disease and sleep apnea and so forth. This is the first thing that's really come to light, and not only obesity, but even equally so or more so, the disparities and inequality that we're seeing. How many more individuals, Black individuals and other individuals of color, are being hospitalized and suffering from this pandemic? Can you bring us up to date on lessons you've learned and some things we should all be thinking about as we come out of this pandemic?
So, one of the key lessons that I've learned when thinking about obesity and COVID is that I do feel that the COVID pandemic shines a light on obesity as a disease in ways that we have not previously seen. We know when we look back at the CDC, when they initially began to recognize how obesity was playing a role in both morbidity and mortality, that initially only those with severe obesity were considered. But then the CDC went back and recognized that it was those that had excess weight as a whole that really played a role in terms of like their sickness and death. Unfortunately, we do know that obesity disproportionately affects racial and ethnic minorities in the country. So it was no surprise to me, and in addition to other demographic factors, particularly that we've seen with regards to health disparities and other diseases, that when we started to see the numbers bore out, that we were seeing greater sickness and death in individuals that were from racial and ethnic minority communities. And what we do know about COVID is that the number one risk factor, unfortunately, for death for persons 60 and below is obesity. And so what I have seen, I think what you have seen, Bob, in Chicago, is a major influx of individuals that finally recognize that obesity is a disease, and that this is a disease that warrants multifactorial, multidisciplinary treatment, because many of them have tried and unsuccessfully been able to tackle this issue, and now need the help of individuals that are dedicated to their care. So I think these are some of the key lessons we've learned from COVID: greater awareness, recognition of the disease in ways that we have not previously seen before. And I'm excited about the potential, associated. I mean, there's bad things. COVID is a bad thing, but for recognition of this disease, maybe not so bad.
Yeah, I hope, tongue in cheek, it's not so bad. I know what you mean by this, but I think this is, I hope, and you do too, a step forward in recognizing the seriousness and the burden of obesity, along with other medications that are coming online, kind of these groundbreaking medications.
Yes.
I hope two aspects and others are really going to change the dialogue and the narrative about obesity. And we'll see over the coming months and years whether that actually is true. So let's turn now, very importantly, Fatima, to overcoming weight stigma in the treatment of obesity. What are the take-home messages we should be thinking about when we're overcoming weight stigma?
So I think that there are a lot of great take-home messages when we're thinking about weight stigma. I think many people are unaware of how weight stigma actually affects health. A little bit earlier in the program, we talked about, kind of weight teasing and bullying and how that affected weight status later in life. But what we have to recognize is that weight stigma actually leads to stress in individuals that experience that stigma, which affect a variety of factors like the eating and physical activity behaviors, things like binge eating, disordered eating, lesser motivation for exercise, for example. It actually leads to physiologic changes where we start to see increase in certain stress hormones like cortisol or CRP, C-reactive protein, for example, increased levels of hemoglobin A1C, which is our average blood sugar, and elevated blood pressure. I mean, I don't think that when we recognize that patients actually experience stigma, that there is this physiologic picture that actually happens as a downstream effect from the stigma that the persons are experiencing. And then what that really does is it affects their access to healthcare services. If they're experiencing stigma, particularly in the healthcare environment, and large studies are consistently showing that we as doctors and other healthcare providers are some of the major perpetrators of weight bias and stigma that individuals experience, it really leads to them not wanting to see us. They don't want to adhere to our care. Why adhere to the care of someone that doesn't respect you or value you for who you are, regardless of your weight status? And so I think that these are extremely important things that we often disregard in patients that have obesity that I'm hoping are coming to light in our discussion today, Bob.
Yeah, I agree completely. In addition to increasing the burden of obesity and the challenges of obesity, I hope this one follows suit immediately, and that is to treat patients with dignity and with empathy and deal with overcoming weight stigma, just as you perfectly articulated. Thank you. I want to finish up now with what we call SMART goals. SMART is an acronym that stands for specific, measurable, attainable, relevant, and timely. We typically think of SMART goals with behavior change with our patients. But I want to kind of turn this around a little bit and think about SMART goals for you as listeners to this podcast. I want you to reflect on your own clinical training and experience and consider ways unconscious bias impacts patient care. Use non-stigmatizing language when referring to patients with obesity. I'd like you to recognize how COVID-19 amplifies disparities in communities of color that exist before the pandemic. I want you to assess ways of social determinants of health, weight teasing in adolescence, and COVID-19 infection can lead to poor weight-related outcomes. And lastly, apply best practices for partnering with patients to set goals, establish trust, and optimize adherence to appropriate therapies. Thank you, Fatima, so much for helping out with this podcast today.
Thanks so much, Bob. It was great being here with you.
Thank you again for participating.